move up front.
Yeah, I guess so. It must be my look or something. I don't know.
No.
Okay.
Here, kitty.
Good time. Well, thank you, David. Thank you very much for inviting me, and thank all of you for coming. On this sunny Tuesday evening, I'm impressed. I really am. The seats have been taken. Yeah, thanks for inviting me. My name is Mark, and as David said, I'm an occupational therapist, and I'm a certified hand therapist. And I offered to David that I could talk about kind of what hand therapy is, more specifically, as well as to generalize it too, to just kind of point out some of the common things that are out there that might kind of best be suited to be seen by a hand therapist, in case you're not sure where this person might be able to go or what type of thing that might be best suited for that type of person, whether it's an injury that happens at home or at work, or whether it may be someone that you know or yourselves. I'll outline some of the things that we can kind of do and some of the unique things that we can provide. So. Give you a little background on myself. I graduated, well, a long time ago. So I've been doing this quite a long time, and I first got interested in doing hand when I was in school as a specialty, and it was in 1994 when I joined up with a hand surgeon actually in Phoenix, and I got to work within his practice, which was a really unique situation that I really loved. So he was really a mentor to me, as well as the other therapists were great mentors to me. And that's where I really decided at that time that I really wanted to focus my career on designating what I do to hand injuries and trauma. And that's my passion, is seeing traumatic hand injuries and helping people progress through that, whether it's just the physical side of it, but also that emotional kind of social connection to being hurt and traumatized as well. Those things come into play so much, and that's where I really learned to appreciate all of the components. I worked in Phoenix for the hand surgeon for about 3 years, and after that I moved up to Abbotsford to start a private practice with a partner of mine. And we did that we had that practice for about 15 years. I've since moved on and away from that practice. I've been living in Bellingham since about 2003, but I was commuting up there for many years. And since April, actually, I no longer am an owner of that practice, and I joined the Capstone group. So now I'm here in Bellingham trying to offer hand therapy services within the Capstone Physical Therapy group. So today we'll kind of outline just the generalities of the profession of hand therapy as a kind of a specialty profession. I'll outline some commonly treated conditions, review some evaluation techniques, and I brought some tools in here as well. And then I'll just kind of outline and point out some of the treatment techniques that we use. I also brought some different varieties of custom splints that we make. Splints, more formally known as orthoses or orthotics. But I thought I'd bring some common things out that you can kind of, handle and touch and kind of slide them on your hands and see what they feel like. I'm sure you're probably very familiar with them. You may have had some of your own, or may have had family or some of your patients that have had a need for them. So I thought I'd just bring some samples as well for you to just kind of fool around with. So hand therapy is a profession. The Hand Therapy Certification Commission is kind of our credentialing body. That's within the U.S. And every certified hand therapist that wants to call themselves a certified hand therapist has to go through the credentialing of the Hand Therapy Certification Commission. And what they define hand therapy as is the quote that you see there, the art and science of rehab of the upper quarter of the human body. So they kind of outline, it's a merging, and this is where it's kind of unique, is a merging of occupational therapy and physical therapy, theory and practice. That combines, the comprehensive knowledge of the upper body function and activity. So it's really utilizing both sets of skills that traditionally can either come from a PT background, but also can come from an occupational therapy background, because there's such a merger between the physical components of the rehab, but also what the occupational side of therapy brings to hand therapy, which is a lot of the custom orthotics. So we do a lot of combining the ideas of how to gain range of motion, for instance. There's the typical techniques of active and passive range of motion, joint mobilization, that the physical therapy world is very familiar with. But we also then incorporate a lot of the splinting, not just as protection, but we use splinting to actually gain motion in many cases. We also use it to prevent motion in many cases, to limit motion during certain phases of rehab. So both of those worlds kind of come together, and that's where occupational therapists and physical therapists can then focus on becoming specialized as a certified hand therapy. So it's really a blending of those two worlds, philosophically and theory-wise. As I talked about, OTs and physical therapists can become certified hand therapists. And what it requires upon the initial graduation of any PT or OT, you have to have a minimum of 5 years of experience as a graduated professional before you can even then apply to become a certified hand therapist through the Hand Therapy Certification Commission. During that 5 years, you have to accumulate at least 4,000 direct hours of providing hand therapy. Which has been a tricky thing to do, where a lot of places are looking for a hand therapist, but aren't sometimes willing to take people on who are not experienced. So it becomes a delicate balance. And I was lucky because the surgeon I worked for was happy to take new people like me that were trying to start in the profession. So I got to mentor from the hand surgeon as well as some of the senior therapists. So sometimes those environments are critical for our development. Once those two criteria are met, there's a national exam that's regulated by the Hand Therapy Certification Commission that's now written twice a year, and it's written now and offered in multiple countries throughout the world. But it's the Hand Therapy Certification Commission that still credentials anybody worldwide who wants to call themselves a certified hand therapist. So hand therapists. What we like to tell people is that we have a comprehensive knowledge of anatomy, physiology, of all the systems. Whether it's the skin, from the surface, muscular, skeletal, nervous system, the vascular system and how it functions. We deal a lot with the early trauma, and we like to see things early. So we like to deal with people who are in that very early phase of an injury, even if they may not be ready for movement, but addressing the swelling, addressing the circulation, addressing the potential pain patterns that the nervous system is reacting to already. And that sometimes is much earlier where we would like to see people than is traditionally kind of done then for people, where a lot of times the assumption is, well, you're not ready for therapy yet, you're not ready for lifting weights yet, so I'll hold you back from therapy. But what we would prefer to see is people right at the very beginning, right after surgery, while the wounds are still healing. We can help with that edema management, that desensitizing the nervous system, help with the pain control, help kind of educate patients on what it is that they are to expect during this initial phase and then recovering into the other phases. So those are some of the parameters, some of the, I guess, the content of what we like to focus on as well, and very early. So we educate patients on the pathology of their conditions. We'd like to be aware of what is the cause of your condition, what led you to this. The mechanism of the injury can tell us a lot of things a lot of times too, that sometimes just receiving the diagnosis doesn't necessarily tell us. For instance, we can see somebody with a wrist fracture, so we're dealing with a distal radius fracture that's in a cast or just coming out of the cast. But if I talk to somebody about the nature and the cause of the injury, if they've had a high impact injury, then I can also assess them to rule out or whether I'm suspecting any additional ligament trauma to that region that often gets overlooked as they recover. So all of those components we try to piece together right from the beginning, and then again, the earlier the better. So again, we deal with a lot of the surgical and medical treatment. We kind of pride ourselves on being experts of not only the anatomy, but how the anatomy functions, the kinematics of a joint and the tissue and how it moves and how it responds to movement and pain, and then the psychological response to that, which is very important too. Again, like I said, we deal with a lot of the wounded tissue healing, and again, earlier the better for us. We can also identify, even in the early phases, what people need to do, what their function requires, whether they're a mom at home that just had a surgery because she fractured her wrist, how we can make her life easier, for instance, in dealing with her newborn, whether she's wearing a brace, or give her suggestions on how to function a little bit easier, or whether it's an injured worker, for instance, that had a trauma, and whether it's even an amputation of a finger or something, that we can engage in assessing their environment, even through just an interview with them to prepare them for what's about to come and prepare them to dispel some of the fears of what's about to come too. So again, we take into account all of these items in kind of treating this holistic person, not just this injury that's come in localized to this body part. So the idea then that we're also trying to promote is, why a hand therapist? Why not just the general neighborhood physical therapist? And again, the two things can be very much the same in most cases. But what we try to promote, again, is this idea that we, through our education, through our background, through our training, is we like to consider ourselves kind of experts in the fine-tuning, the finer things of that injury. So not just dealing with, like I said, with the wrist fracture, for instance, but the finer components that may be an additional sequelae of that, whether it's a potential early startup of a complex regional pain syndrome, whether something is also showing us that there's evidence of another secondary injury with that wrist fracture. So we look at all those little details, again, and fine-tune them along the way. We also really focus on this idea of functional outcomes. We have all these tools that we measure motion, we measure strength, but again, relating it to people's function, whether it's at home, whether it's for them at school, whether it's for them at work, generating a functional goal and combining that with a patient's goal to really create a successful outcome, not necessarily dependent on whether we've achieved normal range of motion or normal strength that we always hear of, but whether they can engage themselves back into activity, and that's really how we help people define whether they're successful or not in their recovery. So what are some of the common treated conditions? And I'm sure that all of you have seen and know many of them. Just out of curiosity, just a show of hands, how many of you have had to actually see a physician or a surgeon for your own hand injury? Has anybody had to actually get medical attention? So there's maybe about a third of you here. How many of you have actually had to have surgery on your hand? So again, there's a few people here. Obviously, David's one of them. I'm still chatting with him occasionally about that. Out of curiosity, too, is how many of you have had either friends or relatives or immediate family that have had actual surgery to their hands? So you can see it's a very common thing. It's one of those tools that we all use, no matter what kind of work we do, no matter what kind of play we do. I always kind of say these are the tools that we use. We use our hands, we use our backs, we use our legs. A lot of us don't use our brains a lot, if you're like me and some people I know, but we use these tools a lot, so they can commonly get hurt. Some of the injuries that we routinely see, tendon and nerve injuries, whether they're due to crush injuries or amputations, whether they're immediately from the emergency room or whether they've been repaired subsequently by the surgeon, or multiple surgical repairs done over time. Those are some of the more intricate things that we would then see. And again, a lot of those we would see very early, especially in tendon repairs and a lot of these wound healing ideas, because you can just see with a wound, especially with crushing injuries, there's a lot of swelling, there's a lot of trauma that's going on, there's a lot of pain associated with it. So helping someone through those really early phases is critical. These examples where there is a lot of swelling, they can have these secondary effects that are very detrimental long-term. Joint stiffness. Those are some of the most common problems that we deal with when things are not attended to early. And it's really difficult to work backwards then from having everything healed, and once the swelling is controlled, then dealing with the joint stiffness later is always more difficult than dealing with it along the way where we can have a more immediate effect. Wounds, infections, obviously, as they're being treated. We do a lot of wound care too, and bandage changes and that kind of thing. So we're trained in that as well. So the people who are seeing their attending physicians who need bandage changes, or if they may be getting nursing care, they may be getting home care for certain things, we can also provide that service as well, right from the very basic wound care phases. Fractures, dislocations, sprains, some of the more common things that you may have all experienced too. Finger dislocations are very easy to occur. I've had them happen in people who are just riding their bike. I've had them happen commonly, people walking their dogs. The dog pulls and they slip, and all of a sudden they're on the ground and they're dislocating a finger with what seems like a very minimal impact injury. So it can very easily happen. So the general tendency is, well, I need to go to the doctor, go to the emergency, get my finger put back in place, but then what? And I find that the follow-up after that is somewhat variable. People are maybe told to put it in a splint. So they leave it in there, but to what extent and in what position is it in? Ideally, we want to certainly position certain joints in ideal positions after a traumatic injury, especially a dislocation or a fracture. And again, those left unchecked or in a non-ideal position situation can create problems later on with abnormal movement patterns or loss of motion that can be permanent. So those, again, are the kinds of things that we like to see early, even if the early intervention has already been provided with the initial splinting or cast or whatever it may be, just to think preventatively along the way. Amputations, burns, frostbite. Amputations, at my practice in Abbotsford were very common. There is such a heavy mill industry and wood industry out there that amputated fingers of varying degrees and of varying numbers on any given person was a very common problem. And oftentimes it seems like a simple thing. Once it's healed, it should be fine. But again, it can create a lot of joint stiffness. It can affect the adjacent fingers of that injured joint or that injured finger. There's a lot of issues with hypersensitivity and nerve-related pain that can happen at that amputated site. So we can work very early on motion. Again, edema management, desensitizing, pain control. And a lot of these people are dealing with the psychological component of that trauma as well, because that's not going to grow back. They're not going to be essentially like they were before with the appearance of it. And that component takes a lot of discussing. And oftentimes, with our clinic, when we have an open environment, it's actually very therapeutic for people to see other people in the same situation. And I'm sure that you've all seen, probably know people with varying degrees of finger amputations. It's much more common than we think. And having people exposed to that in our clinic is sometimes psychologically therapeutic as well as the physical part of the therapy that we're doing as well. Some of the other conditions that aren't necessarily related to trauma, rheumatoid arthritis, osteoarthritis, where there's essentially a lot of joint deformity and associated pain that can come with it. With joint deformity and with pain with positioning, that's where we get into a lot of education with patients. To teach them joint protection and just energy conservation, activity modification types of suggestions that are very basic that people just aren't aware of how to think about that sometimes, of how to take the stress and strain off of your joints to prolong the idea of the motion and function, rather than being more debilitated because you're actually affecting more and more stress on a joint. So a lot of times education is what we can do for a lot of those patients. Guide them on how to manage their pain, because their pain is going to fluctuate too, depending on seasonal changes, depending on their activity levels, and depending on time as they continue to age. These changes will become more prevalent as well. With joint deformities, with rheumatoid arthritis, for instance, there's varying types of positioning splinting that maybe we do to help people either during function or just to give them support for a comfortable position for sleeping, for instance. And again, they're just tools to use to give them comfort and to also prevent further deterioration, to be, not that we're going to stop the process, but we're going to maybe slow down the process a little bit to give them a little more time without having to undergo maybe a surgical procedure, or just to help them manage their pain with that prevention as far as positioning. Things like Dupuytren's contracture, where there is these nodules, this tight fascia that bands in the hand. That's a genetic type of a condition that can develop over time. There's not a lot we can do with that conservatively, unfortunately, as therapists, but we can at least guide people on what to do, identify what it is, and then what to do about it and where to seek help, referring to surgeons, for instance, and then certainly helping them after the surgical care to, again, restore motion, help with the wound care, help with pain management.